Welcome, everyone. You are in the right place. You're not Zooming in for a performance of Hamilton at the Richard Rodgers Theater on Broadway in New York. You are joining us this afternoon for another edition of the C6 seminar series, Collaborative Conversations with Families to Advance the Clinical Care of Children with Medical Complexity and Disabilities. My name is Cara Coleman, and I am the Director of Public Policy and Advocacy at Family Voices, who is a partner in this seminar series with Lucille Packard Foundation, SickKids Toronto, and Northwestern. So why are we playing Hamilton to start off a discussion about pain and irritability? Perhaps Hamilton is the answer, or one of the answers, the way to soothe some pain and irritability. I know for my daughter Justice, it very well would have been, as she enjoyed music. But we chose that music in particular because of the title and what we're trying to do with this seminar series. We're trying to advance collaborative conversations. And of course, we wish that we all were in some sort of large conference room or a theater on Broadway discussing how we take care of our children together in terms of pain and irritability and all the other topics. But that's not possible. And so we saw in a lot of the evaluations and feedback that people appreciated the mix of formal and informal and wanted ways to connect more. And so you are today in the room where it happened, where we have amazing people with us to talk about some concepts of pain and irritability and how we could advance that care. So first, before we hop in, just the minor housekeeping things, two things that I must read to you. Remember that you submit your questions through the Q&A, and the chat is going to be used for comments or, praise already for our Hamilton songs and otherwise in support of each other in that way. And then in terms of getting your CME credits, it's really important that you fill out the evaluation that will come to you after today's session. It will be emailed to you. It is due October 25th. So attend with us today, participate, and then fill out that evaluation. We anticipate that there's going to be a lot of questions today. We'll do our best to get to them within the time that we have allotted. And we're also going to be trying out where we stay on, and not everybody, but where we record answers to the questions, a sort of extra Q&A that will be then emailed to you. So you will get to all your questions, just not maybe within our hour time slot. So housekeeping aside, let's get to that room where it happened. I am so honored to introduce two of my colleagues as family leaders, Sarah Tuller from Idaho and Shonda Hicks. I'm going to invite each of them, do a brief introduction, and then invite them to speak to us for a few minutes. So Sarah, as I said, is from Idaho. She's from the Treasure Valley in Idaho. She works for Idaho Parents Unlimited, using her own personal experiences navigating the massive and multiple systems of care with her son, Truman. And then also her professional experience as a family leader and a parent educator in Idaho. Sarah, can you share some of your experiences raising a child like Truman with a lot of medical complexity and neurodisability that are illustrative of the pain and irritability issues that all of our children face? And then also talk about what you see as sort of implications for change drawing out of your own personal experiences.
Sure. Thanks for having us all on here. I'm excited to share our story. I think it's important to educate all of you on here. I'm going to start really quick with how it all began. I think that's important to kind of mold you into our journey. Our youngest son Truman was born at 26 weeks gestation, so micro preemie, for no reason. He just was in a hurry to get here, apparently. He weighed about 1 pound, 10 ounces. So when we talked to our friends about that, he was the size of a ruler and his head was the size of a Granny Smith apple. So that's pretty little. And the only way to judge pain at that time and discomfort and irritability was by his blood pressure and his heart rate. So we were constantly living with our eyes glued to the monitors, whether he was uncomfortable or feeling agitated. And, when that was the case, we would ramp up the medication to kind of calm him down. When you're an infant that young and you don't speak words, so we'd go off of monitors. Fast forward to our journey, he wasn't diagnosed with CP until he was 1 and about 15 months old. And that was just due to the wait and see model, and multiple specialists and all of that fun stuff that goes with it. We lived in the NICU for about 4 months, 121 days to be exact. And it was quite the journey. When we realized that he had some of these physical complications and the high tone, the plan of care was Botox, and he was had high tone in all 4 limbs. So at that point, we were able to carry him everywhere in his little car seat or in a stroller. So we would see the physical medicine doctor, and we actually did see him in an adult clinic, and I'll talk a little bit more about the adult experience as we move into another part of the story. But he would receive his Botox injections in his calves, in his thighs, in his biceps, and his forearms, and then 1 in his thumb. So 9 injections about every 6 weeks, because he was so high tone, and that's a lot. And when you're injecting that into a teeny tiny little body, I was advised that we might hit bone, like it was no big deal, but that's painful to me. And by 3 or 4 years later, little Truman was just so used to it that we would do the injections and he wouldn't even flinch, and that's what broke my heart. It wasn't the actual injections and hurting him, of the needle going in that was hard for a mama. It was the fact that he didn't feel it anymore. It was to be expected. And that was really hard to relieve pain and spasticity and high tone. That was the way we did it. And it was very hard. And over the years, Truman, because of his complications and the spasticity and the CP, we don't have verbal language. And he's 16 now, and we're still learning how to communicate with him in a way that everyone around him can understand what he needs and what he wants. So when he was about 5 or 6 years old, we were introduced to the spasticity clinic, where they were doing baclofen pumps for the littles at that time. He was still pretty little, but we decided to take a chance, and we decided to go ahead and do it. And with the complications that had, major spine issues, and we had it's the size of a hockey puck, and when you put that in a tiny little kiddo, it's huge. And then the catheter is inserted above here and is above T2 all the way down. It's the top of his spine, because his spasticity is in all 4 limbs. And however, it was life-changing to not have to go get those Botox injections every 4 to 6 weeks was life-changing. But the issue was that we were in an adult clinic, and that was hard. And having him be nonverbal, it was hard when we were asked what's his pain. I'm like, oh, well, I don't know. He's not telling me, and he's really a smiley, happy kid. So when you talk to him, he smiles, laughs, and he loves actions. So there was no real way to measure his pain, other than when he was nervous, irritated, or in pain, he learned how to throw up, and let us do that. So, and that's how he got out of doing things, or telling us that he was nervous, or telling us that he was afraid. So I learned, we were conditioned to take towels and changes of clothes everywhere we went, to this day. Even when we talk about we're going to go to the doctor, it's not a pokey. We're not going to get pokes today. We're just going to be talking about your care and all of that. When we have six to seven specialists every 3 to 6 months doing all these follow-ups, and we have that conversation a lot, and he still will have that gag reflex and throw up no matter how much we talk about it. We can talk about it days ahead of time, but that's just something that he's learned how to communicate on his frustrations and his fear and all that stuff. So the couple of things that, we are hoping to get out of this and educate is, maybe figuring out how to get these nonverbal kiddos a way to communicate their fears and their irritations, because that pain scale doesn't work for our kids. And we do have some great specialists that will speak directly to Truman, and that helps him feel comfortable. So I could talk all day, and I don't want to do that because I want to not take everyone's time. But I appreciate you letting me share a little bit of our story, and we'll probably talk more about that as we go through. So thanks, Cara.
Thank you so much, Sarah. And I love that you pulled out right away, really, that theme of communication. It doesn't have to necessarily be with words, but we all need to be in tune with each other. Even you sharing that, I'll choke up saying about it, that heartbreaking point at which seeing your child's tolerance for pain be so high and that has to be the norm, or does it? That's heartbreaking, and that requires some communication. Thanks so much. Shonda, I'd love to move to you now. So we're moving from Idaho. We're staying on the West Coast with our family leaders this time. And now we're moving to Washington State, where the amazing Shonda Hicks works with the Washington PAVE, which is the F2F, the Family to Family Health Information Center in Washington, and Idaho Parents Unlimited is in Idaho. And Shonda has worked there for 4 years as a program coordinator and family navigator. She's also a LEND fellow, and she is the proud mama of 3. And one has Down syndrome and one has, I've been practicing this, trichotillomania. I don't know if I did it okay, Shonda, but share with us, please, about your experiences with pain and irritability and what you think from your experiences lead to some implications for change.
Yeah, thanks, Cara, and thanks everyone for participating and being here. I'm going to focus in on my son. He is 15 now. He has a diagnosis of Down syndrome. We did know in utero that he would be born with Down syndrome. He was born at 32 weeks, so he was premature. At that time, he was actually 6 pounds flush. So I can't imagine what that would look like if he went to full term. And we were very grateful that he was such a healthy baby. I did spend 4 full weeks in the NICU with him side by side. They thought he had Hirschsprung's at the beginning, so we did get to move to an ICU. Things mellowed out and we were able to take him home. The first real indicator of any kind of pain and irritability came when he was about 3.5. They thought he was deaf. And so we did a couple of surgeries, put some ear tubes in there to try to see what was going on. Turns out that they transferred his care to Seattle Children's. He had a cholesteatoma in his left ear, which is a benign tumor that is a bone eater. So it's also linked to meningitis many years ago, and it has the opportunity to eat a lot of little tiny bones that happen in your ear. And that's what it did for him. At 5 years old, they did ear flap him, and they did some reconstructive surgery. They put in a prosthetic ossicles, and we hoped for the best. A couple of years after that, if you have a couple cells of the cholesteatoma left, they tend to grow fairly rapidly. And again, that happened. And I saw a progression in my kiddo of pain tolerance. He does have a diagnosis of Down syndrome, so he is semi-verbal. He's what we call low verbal. He communicates fairly well now at 15, but reflecting back at 5, 7, even 9 years old, he used a lot of communication in behavior, and he learned how to get his needs met through either behavior, pointing, grunting. And now that he has a lot of verbal skills, he's able to identify that with his language but he doesn't. Instead, he actually will mask and hide a lot of his pain. And especially with doctors, because he doesn't want to be touched and poked and prodded. And I saw a behavior or a pattern happening with his behavior where he would be in a lot of intense pain. I'd see a lot of frustration, anger, semi-aggression. And then I would ask him, do your ears hurt? And he would immediately go, yes. So he wouldn't volunteer the information, but if given the opportunity to comment on it, he was forthright and would be honest. So I learned to ask all the time, do your ears hurt? Well, it turns out this poor kid, his ears were hurting 92% of the day. So he does have a genetic allele of MFTHR, so he can't take Tylenol. So he lives on a diet of ibuprofen. And I've asked doctors repeatedly, especially his specialists, to please prescribe a small amount of some kind of rescue opioid or narcotic for him. I don't use it all the time. In fact, we rarely get a prescription, even though I ask, because a small amount, even a 2.0 or 2.5 milligram of something of the oxycodone will give him enough relief to take the edge off, and he gets some kind of pain relief when it's up at that 10 marker. And when dealing with the ear infections and when things get very, very pressurized, that's really needed. And sometimes a trip to the ER is necessary just to get him out of that pain cycle, so that he's semi-comfortable. He was also diagnosed at the age of 13 with a condition called hidradenitis suppurativa, which is a really painful inflammatory skin condition on the autoimmune spectrum. And he does get some pretty bad lesions, raw spots and boils in the cricks of his body, armpits, groin, anything that their skin touches skin. It tends to create a staph type infection and then boils. And he did just start some Humira for that actually this week. And we were very proud that he took the shots like a champ. And we did some brave work and lots of, cheerleading for him. But that's just a small lens into life with Mr. Grayson. I don't want to take up too much of your time because I know that we'll be reflecting back on our stories later. But again, thank you, Cara, and thanks everyone for being here.
Shonda, though, you do have one more minute. If you want to reflect on are there any sort of things from your story and what you shared that you think about that you want to bring out to the larger and sort of the implications for change and as we talk on pain and irritability?
I think for me, the conversation around the narcotics is really super important. Grayson's 15. He does have, like I said, a diagnosis of Down syndrome. I've reflected to physicians, he's not your typical, what you're looking for in an opioid addict, right? So can we just kind of cut that wall down and talk like real people because my kiddo's in pain? The other piece is that at first, they gave him 5 milligrams of oxycodone paired with the ibuprofen that he takes, and he was throwing up like crazy. It was just too much on his nervous system, too much on his system. And I, made the decision to titrate that and try to find the sweet spot for him where he's out of pain, but not elevated or high, according to a physician. And I found that 2.5 for him at his weight and his age is a pretty stable dose for him to be out of pain and still be, coherent and not tired. And I have expressed that to physicians before, and they say, oh, that's great. Thanks so much for sharing. And then I still don't get a prescription for him to be out of pain. So it's a lot of push and pull for a parent. It makes you feel really in this weird, funky spot that you're advocating for your kid in such a fun, funky way that makes you feel guilty and stressed, when the reality is if you could just hear what I'm saying, hear my child, believe that, I'm not giving him narcotics every day by any means, but in a rescue situation where he is just like, his behaviors are so out of control because of pain, then, it's needed. The other piece that I'd love to focus on that thread is the behavior part. When his behaviors are super, expressive and he is getting agitated, I've had doctors reflect, oh, well, he must have a behavior problem. And I pause and I say, actually, he has a pain problem. And it's amazing if I get him to a level of pain management where he can show you his real self, these behaviors subside. And it actually took me a while to actually identify that and sink into that as well, because I went and did the triple P classes. I went and did all of these behavior cognitive therapy classes thinking my child might have a huge behavior disorder. And it turned out, wow, when he's in a really good spot with pain management, he's able to be himself and he doesn't have these high escalations. So reflecting to physicians and again, having those conversations and communicating, this is what I'm seeing at home. This is what my son's able to tell you. And then have, a roundtable discussion in those rooms where we can collaborate into a good plan is it's really meaningful, not just and effective for the parent and for the child, which is the patient.
Thanks so much, Shonda. I mean, we all know that there are lots of diagnoses, as we've already discussed, children with medical complexity and neurodisability, but there's also a lot of labels. And, around pain and irritability in particular, we've just pointed out drug seeking and behavior problems. And that's not so nice and so helpful when you're in a lot of pain. So thank you, both Sarah and Shonda. Now I'm really excited to turn over to the more didactic portion and introduce to you Julie Hauer and Caitlin Scanlon. Julie Hauer, I'm sure to anyone chiming in today and zooming in, doesn't need much of an introduction, but in case you have not heard of her, she's the medical director of a long-term care and respite facility and faculty at Boston Children's and Harvard. She's written numerous publications, including an amazing book, Life with Grace, as well as the AAP clinical report on pain for this population. And she has many research interests and experience in this. And then Caitlin Scanlon, who will also be presenting, is a fellowship-trained pediatric palliative care social worker who's recently transitioned from a major children's hospital into private practice full-time that is focusing on grief, loss, bereavement, and helping support children and families through chronic illness. So I turn it over to you guys and can't wait to learn. Thanks.
Well, thank you so much for that introduction. But really what we really want to highlight is how honored that we both are to be joining Sarah and Shonda in this discussion today. We are so appreciative of having this be a partnership because our work is all about partnership with parents. Let's see, why am I having trouble? There we go. So we have nothing to disclose. Our objectives today are that we're going to look at knowledge gaps in the assessment and treatment of pain in children with medical complexity and really look at areas in need of study, including using quality improvement projects. In this work, the importance of looking at the differences between acute and chronic pain, and in the partnership with parents that we look at the language strategies that we use when exploring these complex topics. I wanted to start with thinking about the population of children with complex medical conditions, recognizing that they have an increased risk of certain pain episodes and problems, and to look at the subgroup of children with severe neurological impairment, recognizing that this is a group with a specific type of pain risk. There is now a proposed definition identified through a Delphi process that indicates children with disorders of the central nervous system with associated intellectual and motor disability and associated medical complexity. And then to highlight that what we do know is that there's different risks depending on the level of disability. And so the importance, to the best of our ability, to categorize children for the purposes of study in terms of intellectual disability as well as gross motor function classification. I also want to acknowledge that the importance of understanding and defining the terms used. And I'm going to start with agitation and irritability, and I've chosen to include neuroirritability. And to just put these together and think of them as descriptive terms that are indicating that a child has an unpleasant state of arousal. And that by identifying that then allows both parents and clinicians to seek the causes by always starting with in children without words, what are the unmet needs that are being communicated? So as we just heard from Sarah and Shonda, this is a process that they learn to understand what their child is communicating. So it could be that a child's indicating a need to be repositioned. A next area would be a child with a change in emotional status. It could be a child that is in a setting that's not stimulating enough where they're bored and frustrated. Or it could be the opposite, that it is a child who's in an excessively stimulating environment and it's unpleasant. And then there's obviously the range of medical consideration, the various acute medical illnesses, acute drug toxicity, as well as acute and chronic pain. In looking at the gaps that we have, a first starting point is to understand the distinction between how pain is generated by first starting with acute nociceptive pain sources that result in tissue injury and inflammation, and that these sources can be identified through history, exam, and diagnostic tests. These sources are a protective form of pain generation, and that when they're identified and treated, then there would be resolution of the associated pain. In contrast, such children can also be at increased risk for aberrant pain generation due to the altered nervous system. The challenge is that these are sources without test or diagnostic criteria for this group of children, and that the goal of pain treatment is symptom reduction, given that we're unable to eliminate the cause of pain generation. With this side, this just now looks at some of the causes to think about it. But what I'm going to focus on are the causes due to the altered nervous system, given that they have an added challenge. So central neuropathic pain, visceral hyperalgesia, and autonomic dysfunction. And to offer up a proposed term of neuropain in recognition that these are chronic pain sources due to the altered nervous system in children who meet the definition of severe neurological impairment without diagnostic tests, and also without distinct features to differentiate one from another, though it's important to recognize at the onset that the chronic management of all of these categories is very similar. And then I also just want to start with the acknowledgement that in this partnership with parents, that we are seeking to understand together when a child has recurrent acute pain sources or nociceptive pain sources, like Shonda's son, and then also recognize the importance of screening for insidious chronic pain that can go more under-recognized, given its significant impact on the quality of life and health outcomes of both the child and family, and that this involves a commitment both as individuals as well as how teams and systems work on behalf of this patient population. When we're looking at addressing the gaps, one place to start is obviously how are we going to measure the outcome when we're attempting to use interventions? So looking beyond just pain reduction, by also recognizing that with chronic recurrent pain, we also want to look at a reduction in frequency. And then also looking at the outcomes such as quality of life measures and outcomes of changes that can be due to chronic pain, such as impairment in sleep, as other areas to measure. The other area that I wanted to highlight is one that's already been kind of commented on here. It's how do we take information about pain for an individual child and translate that into useful information for others? And so I really have come to think of this as that we don't have lack of tools. What we have is really lack of understanding an effective strategy and process so that we can first and foremost seek the expert knowledge the parent has in their child and what have they learned over time, and then understand what expert information can we offer up by understanding what features can be assessed and identified in children without words, so that again, we can take this complex information and make it translatable to others so that then it's believable and that it improves certainty in the moment for those who are new to the child's care. The next area I wanted to just comment on is this gap in chronic neuropain sources by thinking of it as a screening process, because what we're essentially saying is that we want to screen for reasonable certainty that that is an existing source of pain to then initiate chronic pain management strategies. I just wanted to highlight that this is my initial attempt to try to really address this complex topic by thinking in terms of what children meet the definition of severe neurological impairment, identifying when such children have recurrent episodes that include pain behaviors, and that those episodes don't always have a consistent source to explain the recurrent episodes, and that there are other associated features that can be occur with the underlying chronic neuropain sources, so that we can think of this as a strategy to shift from the inherent uncertainty of this specific topic to the best certainty in the moment that we can achieve in partnership with parents. I want to shift now to thinking in terms of symptom treatment for recurrent pain as well as for recurrent pain that is more chronic, and start with non-pharmacologic strategies. I really want to highlight that this is one area solely in need of study so that we can highlight that this is as important as the medications that we utilize for such children. This process of non-pharmacologic strategies is another example of partnership with parents, as well as partnering with other clinician specialists, including physical and occupational therapists. And with development of strategies, always starting with the parent's expertise. What works for you for your child? And then identifying what are strategies that can work for some children so that we can offer them up and assist with identifying ways to trial different interventions and determine what is helpful for a given individual child, and then incorporate that into care plans. Another aspect of pain management is obviously medications. There's the need for as-needed medications when there is breakthrough symptoms, such as Shonda's experience with her son. And then there's the need for scheduled medications when there is a more chronic form of underlying pain so that we can decrease the frequency and severity of the episodes. The guidelines on this slide are from the American Academy of Pediatrics clinical report with the evidence that was utilized to come up with these guidelines. And as with all guidelines, they're not intended to be written in stone, but have factor in both safety as well as efficacy knowledge for this patient population. But I want to now apply that to the more important strategy, and that is, how do we think in terms of managing comorbid problems? And I want to specifically focus on neural problems of spasticity and dystonia in a child who has recurrent episodes with pain behaviors. You can think in a strategy of the interventions, medications in Botox and intrathecal baclofen pump, and then in children when strategies are being used to alternate with neuropain drugs in children with these recurrent episodes, by recognizing that underlying neuropain sources are going to exacerbate underlying spasticity and dystonia. And to apply the same type of approach so that if we have a child who has feeding intolerance and recurrent pain behaviors, we again think in terms of what strategy specific to this constellation of comorbid existing problems might be of greater benefit for a child. The next part I want to focus on is the issue of recurrent pain, and particularly acute on chronic pain. And what I want to bring a lens to is another area that we know to use but has never been studied, and that is the role of breakthrough care plans. The AAP clinical report provides some suggestions in developing a breakthrough care plan. The idea is if a child is viewed as having underlying chronic pain due to the nervous system, that we recognize that medications can decrease the severity and frequency of these episodes, but cannot eliminate all pain generation that can occur. So we want to proactively then partner with parents to develop such a care plan to utilize. And then as we learn specific things, details about a child, then we can update that care plan. And then in addition, what we want to factor in is obviously that such children can also have new nociceptive pain sources that occur, so that again, we proactively anticipate that this can occur, and that testing and evaluation will occur when a parent has concerns that reach a threshold because something seems off and they know their child best. And that we would also factor in if there are new features occurring with the episodes, or that they're not responding in the typical way that they do to the breakthrough care plan. And the idea is again, if this were to be a sole focus of a study, a quality improvement project, we might demonstrate that we actually decrease the need for clinic visits or for a hospitalization or for repeated tests, and we still identify the new pain sources when needed. The next area I want to focus on is to start with the understanding that underlying chronic pain sources may benefit from 2 or more medications. When we recognize that adults with central neuropathic pain, where there are much larger studies that have been conducted, that over half of adults will be on 2 or more medications. But that also demonstrates the importance, and again, another area to bring a lens to that would benefit from just a sole focus, is to have a methodical process before adding a second or third medication, so that we also get at that aspect of minimizing polypharmacy. This just outlines some proposed strategies to include in such a process, that always going back to the basics of a comprehensive history, exam, and repeated diagnostic tests, that we revisit the drugs already in use so that we maximize the dose, that we again revisit other comorbid problems in need of management, and that we consider triggers and event frequency. An example of a trigger gets at a unique consideration for some children. There is a subset of children with severe neurological impairment who expend 30 to 50% less energy compared to the historical group of non-ambulatory children classified to have cerebral palsy. If such a child has an underlying neuropain source, their metabolic rate will increase, given that chronic pain will increase intermittent muscle tensing and intermittent movement. Underlying neuropain sources can also lower the threshold at which intestinal distension will then generate a new pain signal. So this can become a vicious cycle. I just want to highlight this because this is another area without good study to better understand when to factor this into our decision making, so that we're not increasing calories in a child with underlying chronic neuropain without actually addressing the primary source of the problem. Or another unique consideration, so that we're not just generalizing from other populations. And the example I wanted to highlight is the risk of hypotension that is recognized with clonidine. But that risk may not be the same in children who are unable to stand independently, given that such children then will not develop orthostatic hypotension and will not have the risk of fall with injury. The 2 things I want to start with first, the idea of success. And this is the idea of what does success look like when a problem is without cure? So examples, again, of if it's a problem with recurrent chronic pain as an example, so that it can be strategies to partner with parents and then create shared decisions in terms of, are the frequency of episodes infrequent enough, and is there sufficient benefit from the breakthrough care plan, particularly when considering adding a third medication. So again, we balance when to make a shared decision to try another medication trial, or when we make a shared decision to continue to focus on the current strategy for chronic management. And then finally, embedded in all of this is obviously effective communication, another area that would really benefit from study. Starting with, how do we effectively communicate complex information about differences between tissue injury pain and pain due to the altered nervous system, so that we can then explicitly acknowledge that though there is no test to confirm at this point in time, I know with the information that you've helped me identify that your son is at risk for this type of pain. And by identifying that, that helps us think in terms of the broad chronic symptom management strategies that are important. And then communication that gets at expectations of the length of a medication trial before we consider whether that's effective or not, anticipating breakthrough pain and developing a breakthrough care plan, really anticipating worries that pain treatment will not stop pain from a new source, and effective communication strategies such as, I wish I could eliminate all of the symptoms that can be generated. I worry that's not possible. I wonder right now if this is a time for us to rethink the breakthrough care plan and see if we can make that more effective before we consider adding a third medication. I'm going to shift over to Caitlin. I did want to acknowledge I didn't get to another gap, which gets at post-surgical pain, and I've listed a few considerations here. But I just want to highlight before I shift over that the reason I asked Caitlin to join is it's that recognition that this work involves other clinician experts, such as physical and occupational therapists, other subspecialists, as well as social workers, and the psychosocial skills that are part of our work with parents, so that we can recognize when to utilize different strategies, as well as seek expert input, such as recognizing for some families and for some parents, past trauma might have an influence on their current understanding of a problem. And then I'm going to end with that sometimes I'll ask the social workers I'm working with to contact a family so that they can check in with the family and not have me part of the discussion. So parents can just discuss how hard the problem is, but not worry that I'm going to think they're criticizing the care that's being provided. So thank you. And I'm going to now have Caitlin jump in with some of her important points.
Yeah, thank you so much, Dr. Hauer. And so, right, so when we start thinking about that piece of creating whole family care, we need to look at how the family is even being supported as a first step. So that includes their emotional needs and their concrete needs. And if we're looking at emotional needs, who in the family, what roles do each family member play? And that's not only in, calling on the phone for support, but also who are the decision makers? Who is the caregiver for the child on a daily basis? And how can we learn more from them? Connected with that is the concrete needs, right? If we can't help families or make sure that families are meeting their concrete needs, then how are they going to be able to think through these bigger decisions they need to make for their child or for themselves? So are there opportunities to explore whether or not they can get their groceries, have childcare for other children? Are they able to pay their bills, or is that the biggest stressor? And so are there opportunities to find community connections for them, or connections within your own medical community if you have those available resources for families? And when we consider virtual versus in-person support, some of the things we want to think about is virtual support can be absolutely wonderful. It can also cause additional challenges for families. So oftentimes, like online support groups are great, but sometimes families feel judged by the decisions that they are making or are not making for their child based in conjunction with how other families are navigating those things. And Dr. Hauer highlighted this piece, but they may be seeking guidance from different team members at different times. So is there an opportunity to, utilize that relationship that they have with that team member as a bridge to the rest of the team members so that there's a safe space to explore these conversations with a trusted provider there present? Doctor, yeah, thank you. So then we look at, well, what can we do as providers for these families? So first, we often pride ourselves on we're so open-minded and we're coming to this space. But the reality is I am right now at this moment, a combination of every single moment that I've lived prior. And so it is only natural that I have a predisposition to think one way or another about a lot of different things. So instead of creating shame for myself, shame for others, or whether that's professionals or the families, right? Instead, can we use the communication skills that we use with families on ourselves? So we notice that we're feeling a particular way and we say, what is it that I'm really worried about? And then is there an opportunity to wonder with yourself, right? Kind of letting go of that judgment of the space, but genuine curiosity of kind of what is going on, what is actually creating that worry for me, and is it a way to be addressed, right? And some of those worries we may realize aren't necessarily big worries, and other things are going to be experiences that we really want to further explore with these families to get a better understanding of what is actually happening. And we want to be mindful of doing that with our colleagues as well. So if we notice that there's biases coming up for our colleagues, is there a way to engage in genuine curiosity and conversation with them as well to call attention to that? Once again, being mindful that we're not creating shame, but rather exploration, just as we want our families to do. And within that, I think there's a lot of space to think about how we empower parents, right? If we're entering things with curiosity, can we really use their voice? Can we validate their experiences as the expert? The clinicians may have or do have that clinical expertise, right? And then the parent has the parental expertise. So how do we remind families through that communication that we are all on the same team? It's not an us and them. We're on the same team for their child, right? For Truman, for Grayson, to really find that space where we all work together. And then through that, we can highlight those strengths, right? Instead of highlighting the things that we think families maybe shouldn't be doing or isn't helpful, can we look at what the really good things that they're doing and continue to encourage those so that they continue to happen, right? Creating opportunities for families to identify their own strengths. And in their communication, finding consistency. So we heard from Sarah that she had to travel to different centers, right? That is not uncommon in terms of meeting with an adult team or a pediatrics team. Maybe it's somewhere else, right? And so making sure that the messages the family is getting are consistent. That way we can create more consistent care plans. And within that communication, really looking to the child. So we heard from Shonda, right, that piece of it's a behavioral issue. Well, even if it is a behavior is a child's way of communicating something, right? So can we look at each thing the child is doing as a means by which to communicate? So if we're viewing these situations from a total pain perspective, it's not just physical pain, right? It's all of the pieces that go along with that. So are we taking the time to communicate directly with the child, whether that's verbal or nonverbal, addressing them first when we walk into a room, and then taking the time to understand what that communication looks like. Can you go to the next? Thank you. Because at the root of this, right, we are coping with uncertainty. We may not have a certainty for the source of the pain or the irritability. So within that, where can we try to find a little bit more? And some of that is looking at how the family defines and views suffering. Is that in accordance with what the team views, or is that drastically different? And it happens both ways, right? Sometimes we say, oh, according to the medical team, this seems like suffering. And the family says, I'm not worried about that. And then vice versa, the team is like, oh, that's super common. It's not something to be concerned about, but to the family it is. And so it's important to understand where the family is at in that so that we can then provide gentle psychoeducation about kind of what that may or may not be to offset those feelings of blaming or feelings of inadequacy as a parent, right? Parents want to protect their children. They want to take away harm. And in some of these cases, they don't have the ability to change what's happening. And so what can we do then through psychoeducation, through exploration, like Dr. Hauer spoke about? What are the non-pharmacologic strategies? What can we provide for this family to feel like they are a good parent in this space, knowing that they are, but helping them feel that, right? How do we create a sense of agency, of adequacy for those families? And some of that is really exploring, well, what are the things they can do? What are the concrete things they can do for their child that will either help produce hopefully a more calming effect for the child, or maybe they are able to highlight the things that agitate the child, which is just as important. So really finding those spaces to align ourselves with parents. Right, because at the end of the day, as we hear over and over and over, our communication, the words we use are so, so important, right? We heard just a few moments ago about labels and how that impacts families, how that impacts what they think we think about them, which then impacts how they interact with us, right? Or their willingness to trust us in these spaces. And the language that we use about families outside of the room eventually makes its way into the room, whether that's through the EMR, and then another colleague is reading about our subjective experience with the family before entering. And sometimes we see these families on the worst day of their life. And I don't know about you, but I would not want to be judged about the worst day of my life. And so being really mindful about how we talk about families, how we write about families, that verbal and nonverbal communication when we're in the room with families. Families know when we are communicating nonverbally as well. Just as we look to families for nonverbal communication, they look to us. And so being mindful of all of that, reminding families we're on a team, and we may not ever have certainty. This is the best certainty we have at this moment. And so let's figure it out together, or let's continue on this path together, even though we may not have answers.
Wow. Wow, this panel is definitely just formed a team right in front of us. This is clearly the room where it has happened. So many things to reflect on, and just quick want to remind everyone, if you have questions and answers that you've been sitting, holding back, waiting on their bated breath, please enter it in the Q&A. I will move to that in 1 second. I just want to reflect on a couple things and then pass and turn to Sarah and Shonda and Sarah to see if they want to reflect, and then we'll move to some questions. As I said, I think you guys really just formed a team here, and me as a former athlete, for me, a lot of how I live and function in the world focuses on team, and we talk about it in healthcare so much. And, as part of that team, we've been talking a lot about the discomfort and the pain and the irritability that our kiddos feel, that as the whole child and as the whole family and as the whole team. And I think one really important part of that is the shared moral distress that often our providers of all types feel as part of that team in watching this child be uncomfortable. And how do we find, the best certainty in the moment? And I think Dr. Howard's point about, and Caitlin too, about the uncertainty that's around, that's really uncomfortable in medicine, because we're supposed to fix and cure, right? But really, when pain and irritability, more is uncertain than certain. And so how do we work together, putting aside our biases and everything, to find that best certainty in the moment? Thank you guys all so much. Shonda, Sarah, do you want to reflect on anything, or shall we turn to questions?
I jumped like speechless. It was amazing to hear all of that, and just all of those feelings and thoughts are exactly how we see it. And I am constantly reminded that those non-pharmacological ways of determining what's going on, take off the orthotics, do this, those are the ways that we try to determine, as at home as well. And when the schools are calling, have you done this? Have you tried this? Did you change their clothes? Do they need to be repositioned? All of those things are the steps that we go through on a daily basis to try to figure it out. And then to your point, we are trying to, we know that there's so much grace to be given. And we all are doing our best to practice what we learn and know and are taught. And our kids with the most complex needs are the ones who are going to test your knowledge and test your skills, and test our knowledge and patience and skills. And it's remarkable, really.
Yeah, this conversation was fantastic. I want to attest to the identifying different measures before you hit that pain medication piece that was talked about, whether it be deep breathing, sitting in the dark, heavy weighted blankets, sensory toys or sensory integration, de-escalation techniques. And those are all things that we do on a daily basis, and not just my son. Honestly, I utilize them just as much as he does, because when he's escalated as a parent, I tend to lean into that fight or flight because my child's in distress. And so not only have they helped him, but they really help our whole family. And we have these little code words because sometimes with a kiddo that has a neurodisability, you have to get right to the point, right? You can't beat around the bush. You can't be like, I think we should, no. And so a lot of times I will tell him, you know what, breathe. And he knows exactly what that means now because we've worked on it for, a year and a half, 2 years. And my 10-year-old knows it as well. And that means you take one long, deep breath. And then you pause and you do another. And so I can be across the room and see him really start to escalate, from whatever's happening. And I will just mention, I'll even mouth to him, breathe. And, and just to get that sinking in to start the de-escalation process. So as parents, like, Sarah was saying, we utilize a wide variety of tools in our tool bag. Of course, medication is our last resort. I feel in my family, because there are so many other things that can be done to mitigate pain and irritability before we get to that point. And oftentimes it does, if it doesn't do the trick, at least helps.
Thanks so much, Shonda, for those thoughts. We are closing in on the time for the live seminar. So I'm just going to ask one question. And then, as I said earlier, all the questions that have come in, we're going to be handling and we'll make a recording and share. So everything will get answered. Maybe if each of you could share one sort of thought in response to this question. Are there changes or one change you think that health systems and policymakers should consider to support better management of pain for families of children with medical complexity and neurodisability? Anyone want to go first? Have a first, if you had to narrow down to one change, what comes first to your mind?
Well,
For me,
go ahead.
I'm so sorry, I'll be brief. Mine would be the pain scale. Honestly, that would be, I really would look at the pain scale in the lens of children that are nonverbal, children that use AAC communication devices, children that use behaviors communication to come up with some kind of gradient, different types of scales that other people that communicate in different ways would be able to access and use. And that would be a consistent measure to be able to identify where they're at in their pain.
In many ways, mine's similar in that if we don't measure it, and then measure to document it is what I mean by that. And that means figuring out a way to identify an individualized tool that, and then once you develop it, how can it be embedded within the system itself so that it will be accessed and used?
Mm-hmm.
Because right now, it still is, there's so much barrier to the believability part. And there's so much reinventing of the wheel. I'll just give an anecdotal example that part of my work, every child has a pain scale. We happen to use the individualized numeric rating scale. It takes time to develop, but once it's developed, it's very user-friendly. And then we review it every 3 months with a multidisciplinary team. It's one part of other parts, but it's also a working document. Children get older, and both Sarah and Shonda also highlighted that they learn more about their child's communication over time and what those details mean. So it's not just one point in time. And that's why I purposely even had that slide to recognize that pain in this population is a longitudinal process. It's not a matter of a one-time assessment and now we're going to start this medication. So I'll stop there.
Yeah, Sarah, do you want to go?
No, I was
Okay.
just gonna. I know.
And maybe I'm biased as a social worker too, but I think really strong psychosocial support for these families, because parents and families don't have capacity to care for their individual. They love and they want to, but if their cup is empty, they can't pour from it. And so how do we make sure that we're supporting them and their needs so that they can provide the best level of care, so they can take in the information that as a medical team? So I would I would say really strong psychosocial support for families is really important.
Great. Sarah, you got the last thought, and then I have a few announcements, and then we're going to
Perfect.
close the room.
I think through all of our years of surgeries and hospital stays and all that, all the fun things that we get to experience in our life in this area, the one thing that has driven me the most crazy is that pain scale, because I don't know about you, but my pain doesn't always sit on my face. And when you have a nonverbal child who can't tell you where his pain is at, he's going to look at that face and go, I don't know what the heck that means, because it's not here on my face. It's on my back. It's on my arm. It's on my foot. It's in my head. It's on my ear. And I ran across a spot where there was, I spent like a few minutes looking on the internet for pictures of pain scales. Not one of them is easily accessible, even on an app that has pictures of a body part on the front and showing the front and the back of the body in a child, where they can point to where it hurts on them. So to me, that would be the best thing in the world to give to anyone, even an adult who is nonverbal, an elderly person who is nonverbal, a child, anyone, to be able to tell you or show you where it hurts and how bad. That's my soapbox.
Wonderful. Thank you guys all for today. Just a couple announcements. Remember the evaluation that you're going to be getting to get those CME credits. You need to return it by Monday, October 25th, and join us next month on Thursday, November 11th for feeding tolerance with Dr. Muzaki, and who will also be joined by Laura Bresk. And Sarah will be back with us next month, as well as Patricia Dean. So thank everyone for joining today. We really appreciate you for joining us in the room where it happened. So let's go into the questions that were in the Q&A, and then maybe we can all work together through finding the ones that are in the chat. Great question here. Any recommendations or thoughts on, number one, getting non-pharmacological intervention tools paid for, and two, the role of psychology for nonverbal children who seem to be dealing with anxiety and sadness? Those are two loaded, heavy questions. Who wants to take a stab first?
I'd be happy to start. So the non-pharmacologic kind of equipment, essentially, that one is to, I'd actually say parent or the parent support groups within the hospital system. I think they can actually do advocacy to ask that the hospital system have some of those resources available for families that either can't have it reimbursed and don't have the financial means. And that it also becomes a way to trial it. And again, I can just speak from experience that that's what we do. Granted, my clinical work location is a relatively small number, but that way we always have weighted blankets, vibratory mats, and then we'll just recommend to families if they already have a vibratory vest that actually can also be used as a tool to see if it helps during a pain episode, because vibration can help. Advocate within the hospital system in which your child's cared for, and do it through the parent organizations so that they can bring that up, because these are, from a cumulative standpoint, they're kind of low budget cost things for the hospital itself, even though I know hospitals work on small, hard budgets. Then the second is that state agencies can be another resource that can be contacted to see if they can help support, because for the family, the one piece of equipment might be expensive, but the cost actually is often reasonable in terms of, again, seeking out resources that might be able to reimburse for it. They tend not, and then the clinicians themselves can certainly attempt to get reimbursement through the payer system. What was the second part? Because I did have I forgot.
Well, I'll ask that. How about we finish through on that?
Okay.
That's what I should have done first. Let's keep going on that. Caitlin, were you going to chime in?
Yeah.
Yeah.
So I would absolutely echo all the things that Julie shared. And then I think the other thing so this is definitely a well-resourced hospital kind of a thing, but oftentimes there are philanthropic funds through hospitals that would have the ability to provide those things to families if it were a situation in which the family couldn't afford those things out of pocket, recognizing that many families can't, depending on what they are. Another way that we've gone about some equipment things before is having, different professionals within the hospital kind of prescribe those things so that they can go through their insurance companies as a means by which to get some of those things. And then also really troubleshooting, like if you are part of a support group or if you work with, family advocacy programs, talking to other people in similar situations and asking how they navigated this. So instead of like creating the wheel on your own, really looking to the community to say, hey, this is something I'm looking for. How have other people navigated some of this? And that may lead you to an avenue in which you didn't even know existed to be able to obtain the tools that you need in that space. The other thing I would say is look to those professionals within the hospital. So if you're looking for non-pharmacologic tools that are more like smaller interventions you're doing at home, like can you talk to child life specialists and see if they have things that they share with families or tools they give to families? So really looking to those professionals as well to help maybe guide some of that.
One other area I forgot to mention is that looked within the state in which one is living, if there's home-based palliative care services, because those palliative care and hospice are both, because they may have within them music therapy and child life as, again, accessing modalities. That doesn't get equipment, but those can be pretty powerful for some families. Will find that it's quite powerful in terms of how one session will have like 2 days of benefit. And then the second one I just realized I should have said up front is that when writing an order, it's appropriate to write, if you've identified that a child has chronic symptoms, that it's appropriate to write that this is medically necessary, so that it's using the appropriate language. And then you can always reference the American Academy of Pediatrics clinical report, because it does offer up just a few statements as to why specifically equipment that uses vibration and pressure, so like a weighted blanket, have actual medical reasons why they help with chronic pain management. So that we're indicating that this isn't just a feel-good thing, this is actually medical equipment.
Great, really critical link, Julie. Sarah and Shonda, do you have anything to add?
Yeah, I was just going to say that every state has a parent training and information center and a family-to-family health information center. And that is what our jobs are, is to provide those resources based on those state agencies and how families can be found eligible for waivered services that would include those that go above and beyond the state help or the state assistance, and potentially looking at what some private insurances could cover in terms of some of those therapies, OT, PT, some of those services could also provide resources. And that, those are, and then the social media groups have been a huge source for a lot of our families, but agencies like Shonda's and ours are valuable resources.
That's a great point.
Shonda, your thoughts?
I just echo what Sarah says and then add that anything that isn't covered by insurance with a physician's script can typically be covered under DDA services if your child qualifies. And that was something that Sarah was talking about waiver services and the Developmental Disabilities Administration, where you can, they go above and beyond anything that's not covered by insurance, especially for those weighted blankets or those sensory items that are used in home or in hospital to help support and mitigate a variety of sensory or pain, irritability troubles.
Yeah. I'd just add myself too, that in my experience, just thinking about going across systems, early intervention is also a really creative way when you're learning about how to care for your child, and all these communication things we talked about. They're really good at helping families look at, when you're buying a toy for your child, how to buy a toy or take a binder and make it into something that protects their, sensory and gives them, blocks out light, just in creative ways. that are affordable to make things that you need, versus, you slap a label on it and it costs $250 from assistivetechnology.com or whatever. But the other is that, most of these kids are going early intervention and into school and stuff, linking up with school systems, pediatricians and families and IEPs, and the power of what's medically necessary, getting music therapy paid for through school, as well as weighted blankets and all these things that travel with the child, school and home, is another way to just link up, and it helps make that team a little bit broader for the child. So, Julie, you wanted to add one more thing, I think, on this question?
Yeah, actually what I wanted to is to end it with a shout out to this conversation was so rich, to focus on non-pharmacologic strategies and to really give a shout out that there's not enough attention to this, because understandably the clinician side, the medical clinician side wants to make things better with a medication that's prescribed. And we're not as robust in thinking of these tools. It's understandable it's coming from Caitlin and I in the palliative care space, because this is part and parcel of chronic symptom management. And so, because I'm hoping that people will listen to these answers, and that this can just, once again, put an emphasis on this is as critically important as the medications we consider prescribing. Thank you
for looping back around to that point. The second part of that question, if we can go back to that now, was, are there any recommendations or thoughts on the role of psychology for nonverbal children who seem to be dealing with anxiety and sadness? I assume on top of the pain and irritability challenges.
So I'd again be happy to start, but what I want to start with is that there's two equally important parts. The emotional status of the child should always be considered, and it can be under-recognized how that can have an impact. That I consider where we become detectives, literally parents and clinicians, if they're going to collaborate together, become detectives in thinking through this, because this is probably the most complicated. And that's where I thought that Sarah and Shonda, they brought such power in kind of speaking to this aspect, like hearing about Truman's story that he learned to communicate with vomiting. So the first part is to think of it, explore it, and then revisit it. And then the second part is the flip side, that sometimes I will see where understandably families and clinicians will wonder if the reason for these recurrent episodes is the emotional status, without considering pain as an explanation. So, so it's the need. There's benefit when we give equal attention to both sides of the equation, because I often talk with many people. What I do suggest is that develop an understanding of the child's intellectual level. The parents, I find universally, they really have a good sense of where their child is at, believe the parents, and then factor that in, because as pediatricians, we do become skilled at understanding how children can behave at different ages. But what I mean by that is to also not apply an emotional label to a child where maybe their level falls at a 9-month age level, where a child could have stranger anxiety and can be calmed by a parent when there's a stranger in the environment. So that I hope I'm making sense, that it's that idea to both consider it, but not just use it as a blanket to explain without exploring, could there be underlying pain that is the broader factor in looking at the individual child. I'll stop there.
Yeah, I agree, echo all of the things that Julie just shared, and highlight that piece of, is there an opportunity for the family to work with a professional and explore, what is their developmental age or framework, and then working within that, right? When a baby has anxiety and sadness, we approach it differently, right, than a 6-year-old who has verbal and cognitive for a typical 6-year-old, right? And so looking at those pieces together and helping the family assess where the child is at from that standpoint, because even children who are nonverbal, they can still take in a lot of information, right? So just because they're not speaking back to you does not mean that they don't hear what you're saying. And so are we, even just from very simple standpoint, like, are we addressing the child in the room? Is that causing more anxiety? Are we not trying to communicate with the child anything about their illness, or are they worried about it? Right. So I think it goes back to a lot of psychoeducation with families about those things. And then really taking time with the family as the expert to explore, when do you see this anxiety? When do you see this sadness? And trying to navigate, are there things we can put in place, coupled with Shonda beautifully spoke to almost that co-regulation, right, as a parent. So noticing if your child is getting worked up, as you would with any child, okay, can I slow down my responses so I set the tone, we breathe together, or I lower the energy in the space, and do you also feed off of that as the child? So I think it's about working with someone who maybe just knows a little bit more about child development, or about kind of what we typically see, because we probably see more children in this space, but recognizing that every child is an individual. So we work with the family to see when we're seeing these behaviors, knowing that anxiety and sadness feeds pain, and pain feeds anxiety and sadness, right? It's a cycle. So we have to address all of it at the same time. I hope that made sense.
Yeah. No, that was fantastic, honestly. And I will say that for our home and for my child, one thing that he's done almost on his own and in a very healthy manner to help process all of these emotions is my son will go in his room and you'll hear a lot of very loud talking. And he has a myriad of, he collects Ken dolls, and each Ken doll has a name, and some of them are propagated to people in his life. He has a Dr. Otolaryngology doll. He has a pediatrician doll. He has a mom doll, right? And so he will take these guys, which is a super healthy way of processing, right? And I noticed it about 3 years ago. He was talking really loud in his room, and I opened the door. I said, "Everything is okay?" He goes, "No, Mom, I'm fine." And he's like, "Go away." And I was like, oh my gosh, what the heck? So I listened at the door and I could hear him saying names. And then I was like, oh, and I can hear him talking about what happened yesterday. And I can hear the whole escalation of the events. Even if he's not saying the exact words, you can hear the genuflection in the tone rise, and then it fall. And then he comes to this conclusion of, is everything okay? Yeah, everything's just fine now. And then he's done. And he's able to come out of the room. He's processed everything on his own, internalized it, externalized it, mitigated it, and psychologically absorbed it. And now he's like, I'm fine. So giving him that space, though, to be able to do that. And if anyone happens to be visiting our home, explaining to them, this is what's going on. It's totally healthy and fine. He's just working some stuff out. And sometimes it takes 2 minutes. Sometimes it takes 20, depending on the heaviness of the situation. But encouraging your child in their cognitive abilities, paired with the chronological age, to come up with some kind of healthy foundation to be able to process a lot of this stuff, because it is traumatic. And just because he doesn't verbalize that it is to everyone else, doesn't mean that he's not internalizing a barrage of things and holding it in and creating, this heaviness in him. Just because he has a disability doesn't mean that he's not human. And giving him time and space to be able to support that so that he can move on, like we all want to.
Wow, that is some powerful strategy, Grayson.
great.
Amazing. Thank you for sharing that.
I apologize. I don't want it to seem like I always
No,
need
please.
to say the last word. I realize, because people know that I bring the expertise in identifying and treating pain. I think it's important to understand an example of a boy I was involved with. He was a former preemie. I always like to remind people that premature children tend to have better intellectual ability than is presumed, because they have such a significant motor impairment that impairs the actual verbal communication. Anyway, So it was a boy who had had multiple hospitalizations, hadn't been in school for probably a year, came to Seven Hills for respite and then long-term care. Lovely, lovely family. And it was brought to my attention that he cries a lot. And so the specific question was, so we want morphine. And this was from care staff. And this is a reminder that it's not a matter of saying crying equals pain, prescribe a med. A process unfolded, and what became pretty evident is that when a history was taken, the crying happened when he would be brought from his room to go to school, because we had school on site, and then it would stop when he'd be brought back to his room. And we realized he hadn't been in school for a long time, and he loved watching television in his room. So we identified a process to help him acclimate, and started with just something that was more appropriate. He was a very bright boy, but again, couldn't communicate with words. And it was not pain. And he became so happy in school once he was acclimated to the environment and all of the activities that took place. And he thrived in that environment. So again, a reminder that this is requires a very comprehensive, and sometimes the work up front it's hard and it takes time, but obviously the payoff in the long run is huge in terms of the quality of that child's life.
I think, and I'm just going to talk about this super fast and then we can move on, but in the special education realm of the world, we call that a functional behavior assessment. And when kids have a behavior or an action based on something that is maybe causing them anxiety or sadness, we have families request a functional behavior assessment, or the school will request that. And it does that comprehensive view of what's happening before, after, during, what did they do last week at this time, and it really pulls that in, where it would have been determined that he likes to watch cartoons or TV in his room, and then it does look at the whole child. How old are they? Are they just acting their age? I have to tell people all the time, he's just acting like he's 16. Let him be 16. It's okay. Let him get mad or ignore you or all of these other things, because that's what a typical 16-year-old would do. So let him do it. And if he wants to be mad at his mom, my other 16-year-olds, when they were that age, wanted to be mad at their mom and hated their mom for a moment. And I'm okay with that. I'm actually happy that he's acting this age, because, we expect them to do too many things and not act their age or be like their siblings. And so we don't give them that grace. We don't give them that period to do that. So, they want to throw a tantrum, do it. I want to throw a tantrum. Sometimes it's okay.
Yeah, it's hard enough to be a teenager, let alone when you've got all these other pressures and pulling. So let them be kids. Yeah, wonderful point.
The only other, very
No,
quickly. I think the other part that maybe is helpful for families too is we spend a lot of time talking about what brings sadness and what brings anxiety, and taking some time with families to think about what brings joy. So when is their child happy? When do they feel loved? When do they feel comforted? And continuing to build on that to offset some of that anxiety and sadness as well. So as much as we want to assess those things to help prevent them, can we also create a space where they get to do the things that they enjoy, that they like, that bring them happiness?
Yeah, that's that whole child, whole family, and leading, with the quality of life and joy. Like that's what really matters in the end, right? Wonderful point. Thank you. So the next question I see here is a little bit more specific question. So many parents notice pain around GI issues with feeding or passing of stool and gas. And so many of the meds for pain and irritability affect GI. If constipation and gas cramps seem to be a big part of the problem, and gabapentin and clonidine don't help or have bad side effects or side effects that don't help, what other ideas are likely to help?
So there's a myriad of things. I will just give a shout out that in the references from the presentation, there is one on the issue of GI tract problems, so that it outlines all of the considerations to factor in. And I will say that when there's intestinal gas, that is a particular feature that people notice, there's two parts. What might be contributing to it? And then the second is it normal intestinal gas, but that it's actually a trigger for symptoms that, again, get at management strategies. What gets under-recognized about gas production is liquid medications, if they contain a lot of sugars, particularly sorbitol, that can be a contributing factor to it. The second is recurrent use of antibiotics, which then alter the gut flora. And so looking, and I'll just use the term, looking from a lens of, should we be looking at management of small intestinal bacterial overgrowth as a contributing factor to this generation of intestinal gas that's contributing to symptoms. A third is always how well is stooling occurring to allow intestinal gas to move forward and then be passed along with stool. So obviously constipation management. One area certainly worth looking at is formula, though it's a bit of a rabbit hole because there's so many formulas. In fact, I literally right now have an individual where this is the very issue that we're going through all of these components. But there's so many formulas. So on the one hand, for some children, maybe the more plant-based formulas are better tolerated. But on the other hand, is it a subset of kids where they actually have more intestinal gas depending on what plant-based stuff is in that formula? Because some of the food-based products in specific individuals can be gas-forming. So that's what makes it challenging. And so that's kind of a process. Another one is always, and then one other area that is always worth looking at, I already kind of talked a little bit, and that's this complexity of calorie assessment. Assessment. We kind of think of when calories are assessed, they're what's needed, but the best way to think of it is it's an estimate. So to simplify it, I like to recommend to families and clinicians, let's think of separating out that we can define protein and vitamins and minerals and what you need by age, and we can ensure your child gets that. Well, we think in terms of adjusting the total calories. The second, I commented earlier that if something is generating symptoms in such children, it can easily increase their metabolic rate by 30 to 50%. I base that a little bit on I call it a little bit on a lot of experience where I'm struck how many kids, when symptom improvement finally happens, you end up reducing their calories by 30 to 50% if you really significantly reduce symptoms. So I don't want to belabor more beyond that, but those are kind of, from the top of my head, the strategies to think through and go through, constipation being always a very important one to never underlook.
Do any of you other?
Yeah,
we had we have our issue around GI and pain and that it doesn't necessarily have to go around his medications. He is on several medications. We've not had any implications on that, but his do stem around his nerves and his nervousness. We have one in particular doctor, his orthopedic surgeon, go figure, where he had the worst stool and he would eliminate and just have the biggest bowel movements and gas and terrible and whenever we would go see him. And it was kind of like the vomiting issue. I finally realized that was happening every time we saw this doctor. And we love him and he's great and he's funny. And I finally had to tell him that we've got to figure out how to make this not tell Truman, but I did talk to Truman. We did have a conversation, but tell our doctor that we have to make this visit a little bit more Truman friendly so that we don't have to clear out your office. And you can enjoy the rest of your day. Or else we'll be the last one in the day of the appointments. But, you know, it's that communication, and those are some of the issues that our kiddos with pain, irritability, agitation have. Nerves, our gut and our brain are so connected. And I think, get nervous. Our guts get all, tied in knots, and we get all these butterflies. And we have to remember it's the same. It might be the same with our kiddos who are nonverbal and get gassy and, have a giant BM that, then they don't use the restroom. They don't use the toilet. And I did like the suggestion of venting from the gas. That is helpful. Truman does have a feeding tube as well. So that has helped immensely, but yeah.
Thank you for the reminder of, again, going back to basics of venting and trial of, there is a type of equipment that can vent while being fed also. And again, gets at then that issue of payment for equipment, in this case, again, for a medical necessity. Because again, it can make a significant difference.
Yeah, and I'd plug on top of there too that, the power of networking family to family or sharing different stories and stuff. The way that we used to vent my daughter was, it was a pass down from family to nurse to family to me, and we would take these old feeding bags that weren't right, cut, flip them around. And it was a venting bag that handled the whole way. But that sort of non-pharmacological sharing of bags that can happen. I don't need these, you have them, that gets the job done between everyone. Shonda, did you want to weigh in on this question? And then I noticed you guys I don't want to keep you longer.
I just wanted to comment that Grayson has Down syndrome, which is indicative of low motility, right? So he has a low tone, which doesn't just encompass his muscles, that's his intestinal tract as well. So as a baseline, he's pretty in need of a lot of stomach massage. We now use a yoga roller, and I have him lay on it, and he'll just roll back and forth on his stomach. And that's just daily almost sometimes, just because he does need that stimulation, and it doesn't have to always be something that you take orally, like Miralax or something, and then that's kind of like something you do as a last resort. But we also do acidophilus pills, which is a pretty across the board, healthy flora thing to keep everything moving and grooving. But those out of the box, like you're saying, Cara, out of the box things that you just do as a family that sometimes can be the gold shiny star for another family. So sharing those stories of this is what's working for me is always helpful.
All right. I think, guys, if it's okay with you, I know you guys agreed to stay on for like 30 more minutes and we're over that. So sorry, I was not so skilled in my facilitation, but the discussion has been so wonderful. I think unless you guys think there's any particular questions that you definitely want to stay on and do, I think a lot of them we've kind of covered.
There are a few that I can cover quickly.
Yeah, please.
And if it works for others to stay on, but to respect that people took the experience of opioids in children with SNI, more just to reassure that they're as tolerated in this group of children as they are tolerated in typically developing. I think there's always that fear because of the risk of respiratory depression, though certainly starting with maybe a lower dose than the typical starting dose, just so that you trial it first at that in the same manner that is done in the elderly, the concept that you start low and go slow. They absolutely have a role. Kind of a general differentiation is that short-acting opioids are useful for breakthrough pain. They're not useful for chronic pain just because they're too short-acting. And also then just recognizing that chronic pain in children with severe neurological impairment based on adult data that it's more variable in terms of the effectiveness for that type of pain generated by the altered nervous system. But they also can be very useful also for children who are having frequent respiratory illnesses where there can be that sense of just being out of breath, where it can help take the edge off. So I more wanted to just acknowledge they have a role. They certainly require expertise and use. And then somebody asked about the INRS. I know I commented earlier, but more just that it's one of the tools. The American Academy of Pediatrics clinical report goes through the tools and has some information. This one, the benefit is it's individualized, the entire part of it. So I kind of think of it as the parents are in control, because they have to tell us what indicates mild pain, moderate pain, or more severe pain. So it's on a graded scale. And it's very user-friendly for nurses, and it can be used in the post-op period, because that was the initial study that looked at its use. There are other tools that can be looked at. The revised FLAC is probably the other most user-friendly and also can be individualized. And I think those were the big ones.
Yeah, I think your point though about not just taking those tools, taking the time through the whole team to get to know them, to individualize them for each child, and not just there. I mean, we have tons of tools and toolkits and tool belts that just sit around. Yep. And we keep reinventing the wheel. So take that time with that tool and make sure it carries and travels with that child, I think is really the other part of it.
Yeah.
Yeah, I think from that standpoint too, right? Time is of the essence for everyone. But sometimes if we just put a little bit more time in at the beginning and exploring those things with families, then it really does help create more time for all of us in the future, right? Because we're not spinning our wheel, right, every single time. I think the other thing that I think about is, well, yes, many of these children have complicated medical diagnoses and illnesses. Sometimes we try to make the interventions more complicated than they need to be. And so is there an opportunity to also be mindful of just going back to the basics and starting there, even though it's a complicated situation, doesn't mean that there's uncomplicated ways to also think about these complicated challenges.
I think that's
No, go, please.
That is a really important point, that sometimes we're so good at creating these breakthrough care plans as an example. They should be as simple as possible. What does it start with? What features indicate the symptoms? What are your first things? Reposition, personal care needs. What are non-pharmacologic things that have been tried and are known to help? And then one other simple thing, rather than a complicated medication, use this, then 30 minutes later, use this. My recommendation is make it simple. If you're using a prescribed medication because the over-the-counter acetaminophen and ibuprofen aren't consistently effective, then give one of those with the prescribed medication at the same time. It's safe. You don't delay. You're using medications with two different mechanisms of action. Instead of that, wait for 30 minutes. So those are kind of the low-hanging fruit from of Caitlin's point is really important.
Yeah, there's a lot. I was just going to add some sort of acronyms and other things, like what's that old saying? KISS, keep it simple, stupid.
Yes.
Keep it simple, team. And back to the sport thing, it's the fundamentals of sport, and that I think really too is the essence of how in this seminar series we're trying to advance the clinical care, not just studying on the own, but these collaborative conversations. And back to the theme you guys all started with, the importance of communication around this. That time, Caitlin, you just talked about upstream of talking in the beginning more, and then planning simply from there. So thank you guys so very much.
Well, thank you for facilitating this and for taking the extra time.
Yeah, clearly we could keep going and going.
I know.